Welcome everybody to this evening's lecture. Vet Education is proud to present a free lecture on trauma-associated coagulopathy. All right, let's us get underway with tonight's session. Trauma-associated coagulopathy, also known as acute traumatic coagulopathy. What exactly is it? Basically, it's a severe coagulopathy, and it's important to know about it, to focus on severe coagulopathy that can occur following acute trauma. Now, if you're anything like me, oftentimes we see patients that have been perhaps hit by a car, maybe a dog or a cat that's been attacked by another animal, or they may have fallen out of a window or have other sort of trauma. And these patients present to us in a state of shock. And they may have blunt abdominal trauma. They may have bruising to their lungs or pulmonary contusions. And you and I, as veterinarians and veterinary technicians, will do our very best to resuscitate this animal. If it's suffering from shock, we'll put it on intravenous fluids. We'll give that patient pain relief. We'll do a bunch of diagnostic tests to determine whether or not there is a risk of hemorrhage in our patients. And sometimes early on after trauma, we may not appreciate significant hemorrhage or bleeding problems in our patients. However, at some stage following our acute treatment, some of these patients will begin to bleed, and some of them may in fact develop a coagulopathy where we'll measure clotting times and they may be mildly or significantly prolonged. And this is oftentimes associated with significant hemorrhage, either into things like fracture sites, into the abdominal cavity, or into our chest cavity, or into our lungs, or even other tissues such as our brain and kidney, gastrointestinal tract, and so on. And the reason that we're talking about acute traumatic coagulopathy or trauma-associated coagulopathy tonight is that some of our treatments can sometimes make this coagulopathy or make our patients bleed more than we would want them to. So tonight's session is about just raising our awareness of the fact that not everything that we do to help save our patients is helpful all of the time, and that there is sometimes a little bit of risk associated with some of our interventions. So that's just aside from what is acute traumatic coagulopathy, the severe coagulopathy that can occur following trauma. And I've kind of alluded to this already, but why is this important? Well, in human medicine, the presence of a patient following trauma that has a coagulopathy, that either has an increase in APT, activated partial thromboplastin time or prothrombin time, or that has a thrombocytopenia, or that has prolonged bleeding on admission, is associated with an increased morbidity and an increased risk of mortality. So we know, you and I know, that patients that are bleeding can do worse than patients that are not bleeding. It's important for us to be able to get hemostasis in our bleeding patients. But when our patients present to us already with a coagulopathy, it is associated with increased morbidity and mortality. And that's taken from human medicine. How common is it? Well, over 1/3 of human trauma patients have a coagulopathy at the time of presentation. Okay, so by the time these patients arrive at the hospital, over 1/3 of human trauma patients have a coagulopathy that's measurable at the time of presentation. Now, in dogs, we don't have the same sort of data that they have in the human emergency medicine field. But there was a study looking at evaluation of acute traumatic coagulopathy in dogs and cats carried out in 2017. And they found that in dogs, increasing trauma severity is associated with increasing coagulation times. And that means that a patient who looks or who has suffered significant trauma is more likely to have a coagulopathy. So we understand that this acute traumatic coagulopathy is not something that's just confined to the human emergency medicine field, that it does occur in dogs as well and in cats. Certainly more so in dogs based on the results of this study than in cats, but certainly in dogs with increasing trauma severity, there's increased likelihood that your coagulation times will be higher. So why does acute traumatic coagulopathy occur? let's have a look. The first thing is that in a patient who is traumatized, we end up with some tissue damage. And where we have tissue damage, we generally get damage to the vascular endothelium, and that results in exposure of subendothelial collagen. So we oftentimes will get a much greater activation of our coagulation system. Our patients become hypercoagulable. Okay, so that's the first thing. Our patient's clotting system is activated. In fact, in significant trauma, it is estimated that the rate of coagulation system activation is up to 200 times higher than it is in a non-traumatized patient. Okay, so there is a significant increase in coagulation system activation. Now, if trauma is fairly localized or doesn't involve a large amount of tissue, then the amount of activation of coagulation system A is going to be smaller, and secondly is going to be relatively confined to the area of tissue trauma. Okay, so if you have a patient who has trauma to a distal limb, for example, or who has bite wounds just over one limb of their body, then clotting system activation can be relatively confined to that area of the tissue. The cytokines, the chemicals that are released from activated white blood cells and platelets that get released when tissue is traumatized will also cause localized vasoconstriction around an area of localized tissue damage, and that will tend to confine the distribution of activated clotting factors to that area of tissue damage, if you know what I mean. However, if we have a patient who is hit by a car, like this little dog in the picture was hit by a car, okay, this dog has bruising over his entire body. In fact, this dog had pulmonary contusions. You'll see that he has an abdominal wrap on his body, and we're going to talk about that in a few slides' time as well. But he was also bleeding into his abdominal cavity. So this dog had significant bruising all over his entire body because he'd been hit by a four-wheel drive weighing about 2.5 tons. And so this dog has a significant area of tissue trauma, and so subsequently has a massive increase in the activation of clotting factors. In addition, because the trauma in this patient is so widespread, the distribution of activated clotting factors cannot be confined just to a localized area. So activated clotting factors are going to distribute all around systemic circulation. And so we end up with a systemic activation of clotting factors. Once we traumatize patients, and I alluded to this just before when I talked about cytokines, but whenever you damage tissue, we get activation of an inflammatory cascade. Okay, so tissue inflammation results in hypercoagulation due to release of procoagulant cytokines as a result of white blood cells like neutrophils and macrophages being recruited to areas of tissue damage. And when we damage tissue, we get release of phospholipase enzymes, protease enzymes, and so on. We get release of platelet activating factor and nitric oxide and a whole bunch of other things from the local tissue that leads to recruitment of white blood cells to the area of tissue damage. And those white blood cells further activate our coagulation system. In addition, we end up with and one of the key cytokines that's released from macrophages, for example, is platelet activating factor. So that's going to activate our clotting system. In addition, we also get an activation of the fibrinolytic system in our patient's tissues as well to help prevent the damaged tissue from filling up with large blood clots. So our body has a way of keeping in check excessive coagulation by inducing the fibrinolytic system. So we can see in our patients that have significant tissue injury that we get at both a hypercoagulable state, in which we get massive activation of coagulation system, and we get a hyperfibrinolytic system activation as well. So we get a hypocoagulable state as well. As mentioned before, we get severe inflammation will result in systemic dissemination of both these procoagulant and anticoagulant factors right throughout circulation. What this means is that tissues that are not involved in the primary trauma and inflammatory response become involved in the entire coagulation system, procoagulant and anticoagulant factors. So let's say my patient has blunt abdominal trauma, okay, significant bruising to the abdominal wall, maybe the internal abdominal organs. But that's not to say that my patient with blunt abdominal trauma may not begin to suffer inflammation in the central nervous system, for example, or the heart or the lungs or the muscle tissue as a result of systemic dissemination of these inflammatory mediators, as well as the procoagulant and anticoagulant factors. So we might see in our patient even a patient presenting with epistaxis, even though there may not have been any direct trauma to the nasal passages or the head. Now, here's an interesting one. Catecholamines are also involved in the pathophysiology of acute traumatic coagulopathy because catecholamines increase endothelial cell activation and expression of something called thrombomodulin. Now, thrombomodulin is a cofactor for thrombin that converts thrombin to an anticoagulant cofactor. And that anticoagulant cofactor activates protein C, which is a naturally occurring anticoagulant protein, and that reduces the clot duration at sites of vascular injury. So not only do we have a fibrinolytic system in play that's activated, we also have the influence of catecholamines, which are going to be released when a patient is stressed and has sympathetic nervous system stimulation that contributes to activation of protein C, which reduces clot duration at sites of vascular injury. Now, this is important because it's going to mean that our traumatized patients are eventually going to bleed or have the potential to bleed more at the sites of vascular injury. There's been a lot of talk in recent years about glycocalyx. Please type in the chat box there if you have heard about the glycocalyx. I put a photograph of glycocalyx here. This is actually a blood vessel, this big round thing here, and the little hairy layer in between at the lumen of this blood vessel and the little dark area just behind it there are glycocalyx. Glycocalyx is a multi-layered layer of glycoproteins, glycosaminoglycans, and other compounds there that help to reduce vascular endothelial permeability. Okay, so they help prevent proteins and cells and fluid from leaking out of capillaries into the vascular interstitium. However, when you have significant trauma and significant catecholamine release, that exposes or damages the glycocalyx, and that can lead to hypercoagulation and subsequent release of anticoagulant mediators, including tissue plasminogen activator, that results in anticoagulation and hyperfibrinolysis. Now, Candace asked a good question. Is glycocalyx integrity an issue with heterstarches? Good old colloid debate. Absolutely, and I'm glad you raised that because we used to use synthetic colloids like hydroxyethyl starch, the heterstarches, pentastarches, and tetrastarches. We used to use those those fluids a lot in acute trauma, and possibly even more in patients with sepsis or severe illness. And what we now understand is that patients who have a damaged glycocalyx are not able to retain these starches within the vasculature, and so these large heterstarch molecules will leak out of the blood vessels into the interstitium, where they contribute to an increase in interstitial water, and in some organs like the kidneys, for example, they're implicated in causing some kidney damage. So do I administer, or would I recommend administering hydroxyethyl starch or tetrastarch or pentastarch or heterstarch to a patient who has significant trauma, significant soft tissue trauma? The short answer is I generally avoid giving heterostarches or pentastarches or hydroxyethyl starches to these subset of patients. If the patient has mild to moderate trauma, and I see that patient within 30 minutes or half an hour, or 60 minutes or so, and I'm having trouble treating them for hypovolemic shock and getting good blood pressure elevations and getting a good response to crystalloids, I might administer in select patients a one-off bolus of 3 to 5 mils per kilo of hydroxyethyl starch. But if my patient is moribund and it's severely traumatized, has trauma over a large part of its body, then generally I'm not using those hydroxyethyl starches. Hopefully that answers your question. The colloids themselves may contribute to damage of the glycocalyx, but more than that, we are concerned about patients who have damage already to their glycocalyx when we give them these starches, that they might cause further damage down the track. So as I say, hopefully that helps answer that question, but thank you so much for asking that. We also have in the traumatized patient, getting back to our trauma-associated coagulopathy, we also have platelet dysfunction. Accelerated ADP release from damaged tissues can promote platelet activation actually in circulation. So this is platelets being activated without the need for any exposure of subendothelial collagen in order to get them excited and activated. And this reduces the extent of platelet activity at the sites of vascular injury, but it also causes or contributes to the development of microthrombi in systemic circulation following trauma. Couple that with the fact that many times in severely traumatized patients, there will be hypoperfusion of vascular beds. Why do we get hypoperfusion? Well, there's a few reasons for that. And the first reason is that if you have significant trauma, your patient will suffer an activation or have activation of the sympathetic nervous system and adrenal glands, and that will lead to the release of catecholamines and also the release of or stimulation of our sympathetic nervous system, alpha and beta receptors and so on. And early on, we'll get intense vasoconstriction in our gut, our liver, our kidney and skin as well. Well, early on following trauma, blood will be shunted to our heart, lungs, brain and skeletal muscle. But tissues such as the gut, liver, kidneys, and skin will suffer from reduced tissue perfusion early on in shock. As shock progresses, the tissues that are intensely vasoconstricted, those ones in the gut, liver, kidney, and skin, will begin to become depleted of ATP. The vascular smooth muscle cells that are contributing to vasoconstriction will gradually begin to vasodilate because they'll run out of ATP, to put it in crude terms. And so then we get generalized vasodilatation right throughout our body. And if we haven't restored blood volume to our patients' blood flow through all of the vascular beds will be compromised. And this can result in reduced tissue oxygen delivery to our vascular beds. And when that happens, we get vascular damage, we get vascular endothelial cell swelling and rupture, and that leads to then subsequent activation of coagulation. So we can see that this pathophysiology of acute traumatic coagulopathy is really complex. It's not just a one-size-fits-all. There's lots and lots of things that are playing their part here. Couple that as well, that hypothermia, which is fairly common in patients following trauma, and you and I can inadvertently lower our patient's body temperature by giving them cool intravenous fluids. That can contribute to slowing down of the enzyme systems that are involved in our secondary clotting cascades. It can contribute to vasodilatation and reduced oxygen delivery as well. In addition to all of these circulatory problems and the inflammatory cascade and so on, we can also, our patients are frequently acidotic. They frequently suffer from metabolic acidosis, and that reduces the activity of a number of enzymes involved in coagulation, but it also increases the rate of fibrinogen breakdown as well. And so we end up with a hypocoagulable state in these patients due to acidosis. I've already mentioned fluid therapy and cooling our patient down, but it also can dilute any remaining clotting factors that we have in our body. And so we can get a dilutional coagulopathy. We can also raise blood pressure. When we're treating patients with intravenous boluses of fluid therapy, we can raise blood pressure to the point that we can dislodge microthrombi that are in small blood vessels that have been traumatized secondary to whatever trauma has afflicted our patient. And so raising blood pressure can in fact cause hemorrhage in our patients as a result of our fluid therapy. So how do we go about diagnosing acute traumatic coagulopathy? Is it a matter of just grabbing some blood and running an activated partial thromboplastin time and a prothrombin time, doing a platelet count to see if our platelet numbers are a little bit low, or doing thromboelastography if you're in a place that has thromboelastography assays possible? Well, the diagnostic criteria that are taken from human emergency medicine and anesthesia outline the following 6 criteria. We have to have the presence of severe trauma with significant tissue injury. Now, in their criteria, they don't necessarily list or name a number as to the percent of a body tissue that has to be injured, because some of the tissue trauma may be quite localized. It may be caused by a very high velocity projectile, such as a gunshot wound or a vehicle moving along at significant speed that might result in fairly insignificant external wounds. And so we may not fully appreciate the significance or magnitude of the tissue injury on presentation. But suffice to say that a patient who has had significant tissue injury is at a higher risk of developing acute traumatic coagulopathy. Initially on presentation, they found that patients that have that present with hypotension or systolic arterial pressure less than 80 millimeters of mercury are much more likely to develop acute traumatic coagulopathy. A hyperlactatemia of greater than 6 millimoles per liter. The presence of hemorrhagic shock with uncontrollable intracavity bleeding or spontaneously bleeding from a wound or a catheter site, nasal cavity, and so on, as well as a prolonged APTT or PT greater than 1.5 times the laboratory mean. And the 6th criteria is if you've got ROTEM or thromboelastography evidence of greater than 40% decrease in clot strength. So that is what is used in human medicine as the diagnostic criteria. There's a great question that I'm just reading right now. Would we not favor a higher blood pressure when we treat patients with trauma over low blood pressure, considering tissue can get damaged at a higher rate when we've got low blood pressure? And that's an excellent question. And the reason why I'm thinking about my answer is that there's no simple answer to that question. In short, if I can be very, very brief, because it's the topic of an entire lecture all on its own, if I can be very, very brief, we aim for a systolic arterial blood pressure in most patients after resuscitation of around about 100 millimeters of mercury. That's what we're wanting. Generally speaking, I don't want my patient's blood pressure to be higher than about 120 millimeters of mercury after resuscitation. And I'll tell you why. Because if my patient's blood pressure gets up to 140 or 150, 160 millimeters of mercury, a couple of things could be happening. One is that my patient may still be in shock. They may be in that compensated phase of shock where they're still really vasoconstricted. And so I need to do things to help manage my patient's state of shock. So if I have a tachycardic patient with a really high blood pressure, I may choose to give my patient a little bit a bolus of IV fluids. And that paradoxically might bring my patient's blood pressure down. But if I have been giving my patient intravenous fluids for 20 or 30 minutes and I take a blood pressure and my patient's blood pressure is sitting at 160, I'm a little concerned, because a blood pressure that high could result in, if I'm keep giving my patients IV fluids, it could result in those IV fluid boluses dislodging blood clots from damaged vascular beds. So there is a fine line to be to be threaded rather. Fine line to be, I'm mixing my metaphors there. There's a fine line to be walked. Let's put it that way. Fine line to be walked when we're targeting a blood pressure. So my target's generally around 100 to 120 millimeters of mercury. I don't want it much higher than that, and I don't generally want it lower than that. Why 100 to 120 millimeters of mercury? Because at that blood pressure, my mean arterial blood pressure should be around 70 millimeters of mercury, which will perfuse my kidneys really nicely. At systolic arterial blood pressure of 100 to 120 millimeters of mercury, I'm going to get good cerebral perfusion. So that's why I'm aiming for that. Now, there are some circumstances, one being pulmonary contusions, and I've just written a blog article on fluid therapy for patients with pulmonary contusions. It's going to go up on our website probably tomorrow, exactly on the subject of fluid therapy in patients with pulmonary contusions. Whereas if I give too much fluid to my patient with pulmonary contusions and I cause some of this coagulopathy that we're just talking about now, I could end up with my patient bleeding a lot into the lungs. And we know that that's going to make breathing more difficult for our patient. Our oxygen saturation is going to go down, and we could end up with a patient that needs ventilation therapy and may even die. Secondly, in patients with severe blunt abdominal trauma, if we increase blood pressure too much, we can end up causing dislodgement of blood clots from our vascular beds in the liver and the spleen, and we can end up with a patient that has a significant hemoabdomen in those patients. So there is a concept in which in non-head trauma patients and non-kidney failure patients that we might resuscitate to a slightly lower blood pressure than 100 millimeters of mercury, maybe 90 millimeters of mercury for a little while, okay, for maybe 2 or 3 hours, just to make sure that our patients are not getting excessive rates of IV fluid therapy. And that can help some of those patients. But check out the blog that's on our website on veteducation.com.au. There's a tab there called blog, and it'll be up there, I think, in probably on the 9th or 10th of February. All right, let's have a look. I'm going to just draw your attention to the courseware that has brought you this lecture, Emergency Medicine and Small Animal Practice. We've talked about the fact at the start of the lecture, it's a 5-week online course for vet nurses and technicians. We've run this course quite a few times before. It's been fully updated. It has new information, brand new formats in terms of the content and references that are available for participants to download. Generally, in our last time we ran this course, we had about 15 separate protocols and cheat sheets that we made available for people to download and use in their practices. So we really get on and make this as relevant for the people and participants who are taking part in the course. So if you have a particular desire to source a resource or have a particular resource for your practice, we go ahead and we make that for you and everybody else who's doing the course. So we try to do our very, very best. It's race approved for 25 points, as we mentioned before, and we have tons and tons of fun in the course. And thank you, Sharon. She said it was great when she did it. Thank you so much for that feedback. That's awesome. All right, starts February 21st. Let's get back into how we can treat this acute traumatic coagulopathy. The first thing is hemostasis. It's very, very difficult to save your patient if they're going to continue to bleed. So we need to look at some way of forming hemostasis in our patients. And this photograph here on the screen is of free abdominal fluid in a post-traumatic patient. We can see the kidney is right here. We can see this black material here is all free abdominal fluid here in a patient post-trauma. In post-trauma patients that have free abdominal fluid, if it's blood, if you're doing abdominocentesis and diagnose your patient has a hemoabdomen, this blood usually, and I say usually hasn't come from a single bleeding blood vessel. It is usually oozing out of organs like the liver and the spleen. You might get some oozing out of the renal capsule as well, but the liver and the spleen are usually where you'll find blood just oozing out. So how do we obtain hemostasis or stop this oozing in patients that have blunt abdominal trauma and a hemoabdomen? Well, we're going to answer that in a in a second. But you could also have bleeding into the thoracic cavity. You could have bleeding from external wounds. You could have bleeding from a fracture site as well. Anyone noticed after animals break their bones or fracture their femur or humerus or tibia, for example, that around that fracture site oftentimes is a really, really big, hard, awful swelling if you wait a little while. And that is blood, because the bone marrow is very, very vascular. So when a bone gets fractured, all of those blood vessels in the bone marrow are ruptured and they all start to bleed as well. So we need to think about bandaging those fractured limbs, to apply compression bandages like Robert Jones type bandages. So just thick padded bandages that are gently compressed with a cohesive, slightly stretchy sort of bandage that enables you to put a bit of compression on that. As far as the abdominal cavity is concerned, we can place an abdominal wrap on our patients. I'll show you a diagram, a photograph of an abdominal wrap on a dog. And I'll also, in the recording, I'm actually going to put a little extra thing there for you, which will have a video of me applying an abdominal wrap to my own dog several years ago, not because he was traumatized, it was using it for demonstration purposes. But we do certainly put abdominal wraps on. There's a great question from Amelia. Should we avoid doing abdominocentesis in these patients? I don't generally, because we're not, it's not generally a high pressure cavity that we're putting our needle into, so we're not going to get blood gushing out of our abdomen. You just do a abdominocentesis with I usually use a 22 gauge needle and a 3 or 5 ml syringe, just to pop it into wherever your ultrasound picks up this type of fluid here, and just draw out 2 or 3 mils, get a PCV total protein. You can measure things like lactate and glucose in that fluid as well. You can measure bilirubin and also urea if you're concerned about urinary tract rupture. You can measure urea. If you're concerned about biliary tract rupture, you can measure bilirubin. So you can do a lot with that fluid. And you can, and so generally speaking, that's all I'll do. And then we'll put the abdominal wrap on our patient. Do I do cystocentesis? Generally not in the traumatized patient. I'm more likely to want to put a urinary catheter in those patients. And again, when I put on my abdominal wrap, I'm usually putting a urinary catheter in. So, here's the abdominal wrap here. Here's the photograph that I showed you before of this little dog. This dog was hit by a car, and he initially presented with not too much in the way of abdominal injury at all. He did have some B-lines or lung ultrasound rockets when I ultrasounded his chest, so we thought that he may have had some pulmonary contusions. And so we did take it very, very carefully with him with regards to fluid therapy. We resuscitated him to a systolic arterial blood pressure of around 90, 95 millimeters of mercury. His heart rate at that stage was still sitting around 160 to 170 beats per minute. So he was still in a mild state of shock, I would have said, but we held off on giving him more intravenous fluids because he'd been hit by a big car and he had pulmonary contusion. So I was not that keen to give him loads and loads of IV fluids and risk his breathing getting worse. But what we did is, at 2 hours after we gave him treated him for shock, we ultrasounded his abdomen, and he had a developing hemoabdomen. And so he had fluid in his abdomen. He just had an abdominal fluid score of 1 out of 4. And we ultrasounded him about an hour later, and his abdominal fluid score was 2 out of 4. So we put an abdominal wrap on him. Essentially what you're doing here is you're putting on a thick padded cotton wool type bandage around the abdomen. You'll notice here that we have a urinary catheter connected to a collection bag in this dog. And he was a male dog. And so we wanted to wrap the entire abdomen, so we put in the catheter in there so we didn't have to worry about him urinating and getting the bandage all wet. But it also has an advantage in that we can measure how much pressure we have in his abdominal cavity, and that's really, really important. So basically, an abdominal wrap to get hemostasis in the abdomen. Apply a soft padded bandage around the abdomen. Now, if you haven't got a pressure manometer and some of the things I'll show you in the next slide, what you can do is just apply this bandage so it's tight enough. So you put the cotton wool on, don't stretch the cotton wool, then you put on this cohesive elasticized bandage here and tighten that bandage just tight enough so that you can easily slide 2 fingers underneath the cotton wool against the skin. It shouldn't be any tighter than that. If you can't squeeze 1 finger or can't squeeze 2 fingers underneath there, you've probably got that bandage on too tight and you should loosen it off a little bit. What we want to avoid is intra-abdominal pressure that's so high that we start to cause compression of vasculature or blood vessels within the abdominal cavity, and that can lead to decreased perfusion of our intestines and our spleen and our liver and everything else. So we need to reach a happy medium where we're just providing enough pressure in the abdominal cavity that we compress the size of the blood vessels. Now, I'm going to show you what I mean by attempting to draw something. If I halve the diameter of this little blood vessel I've just drawn here to that there. So if I halve the diameter, it increased the resistance by 4 times. Okay, it's 1 over the radius squared. So resistance is proportional to radius, 1 over the radius squared. So if I halve the radius of my blood vessel by applying external compression to my abdominal cavity, I increase resistance to blood flow through that blood vessel 4 times. And so that's the principle behind putting an abdominal wrap on your patient's abdomens. Now, you can buy commercial abdominal wraps that are inflatable. You can use that. They inflate a little bit like a blood pressure cuff, and you can get ones that are full suits for the animals that actually fit over their back legs, and you can inflate the compressed blood vessels in the back legs as well as the abdomen in order to try to get as much blood sitting forward of the diaphragm as you possibly can in these patients. They come in a variety of different sizes. I personally have not used them, but I do use abdominal wraps a lot in these patients. So some of you will have been reading ahead and will have seen intra-abdominal pressure. How can I measure it? Well, it's actually super easy to measure. You just need a urinary catheter in your patients. You instill 1 ml per kilo. So you empty the bladder out once you get your urinary catheter in, then instill 1 ml per kilo of saline into the bladder. And then you just attach a pressure manometer like you would have on your Doppler blood pressure monitor, so a little circular blood pressure monitor. And you just attach that to a 3-way stopcock, and you can measure intra-abdominal pressure in millimeters of mercury. Normal intra-abdominal pressure is 0 to 2 millimeters of mercury. Pathological intra-abdominal pressure increases, which can occur in patients with septic abdomen, for example, is up around anything above 12 millimeters of mercury, can lead to dramatic hypoperfusion of the intestines and can cause significant issues as a result of that. So we don't know, and I've put maximum of 7 to 10 millimeters of mercury. The reality is that in veterinary medicine, no one has done the studies yet to determine the ideal pressure to have these abdominal wraps pumped up, okay, once tightened in patients with acute abdominal hemorrhage. So what I've put there is a maximum of 7 to 10 millimeters of mercury, because in people we know that abdominal pressures greater than 12 millimeters of mercury are associated with worse outcomes in patients with what they call abdominal compartment syndrome. So in dogs and cats, I would be wanting to keep it well clear of that. So it might be that you might get significant arrest of bleeding at 5 millimeters of mercury pressure, or even 3 or 4 millimeters of mercury pressure. The short answer is we don't know, but stay away from pressures higher than sort of 7 to 10 millimeters of mercury. Here's a setup here taken from this paper published in 2012. So we have our urinary catheter, which is generally just a Foley catheter put into the urinary bladder. We've got 3 different stopcocks here, all right. And this one here is your IV infusion bag. Generally speaking, I don't think you need probably that that IV infusion bag. I think if you've got just 1 ml per kilo, probably you just need this syringe here, which is a 60 ml syringe, where you can just instill 1 ml per kilo into your patient's bladder. And then what you would need is just to connect your blood pressure monitor. So if I draw that little monitor in here, so I'm such a good artist. For those of you who are looking at this art for the first time, I'm sure you'll be incredibly amazed. So here's our blood pressure monitor. What you do need is definitely some tubing here that is, oops, I'll just bring my arrow back. What you do need is some tubing here that just contains saline. And then you need a fair bit of air before you connect it to your blood pressure monitor manometer here. Because you don't want water to get up into your lovely little mercury manometer. So that's what I would recommend. You need some pressure tubing, so the water will come partly up this tubing here that I'm pointing to. Then you should have some air in this part of the tubing here before it's connected to your pressure transducer and your monitor. Hopefully that makes sense. Interesting comment here. Hypothermia obviously affects coagulation, as we talked about before. Would the warmth created by the bandaging help this patient? It's not going to hurt. I don't know that anyone's looked into the specificity of how much warmth we get just by bandaging the abdomen with a compression bandage, as we've just talked about. But think of heat loss from your patient as pretty significant. We get quite widespread vasodilatation in the decompensatory phases of shock. So peripheral heat loss is really pretty significant. Heat loss through limbs, heat loss through the tail, and those sorts of areas, even heat loss into the gastrointestinal tract. So putting, socks, bubble wrap, those kinds of things, thermal blankets on your patient, and also then space blankets on top of them, getting warm air underneath those blankets there, so that you, with a bear hugger or something similar, so that you can warm that patient up, and warming your intravenous fluids as well. Siobhan's just asked a question: is there air just above the pressure transducer? Just below the pressure transducer, there should be air there. And the system that I have used, and I neglected to take a photograph of it. Essentially, I had let me bring back my drawing tools again. I had my patient's urinary catheter ending here, and I had some IV tubing that ran up like this here. My fluid level, which I'm going to try and draw in blue, was up to here. So this here was all fluid. Okay, I had saline and urine and fluid in there. And then if I can bring my orange pen back again, this here was then connected to my little round monitor, so that air did not go up into the monitor itself. Hopefully that makes sense. As we've already mentioned, we want to bandage fracture sites and other sites of bleeding. And then there's a concept of damage control surgery, which again is probably a subject of an entirely separate webinar. But I have written a blog on this, on damage control surgery, because it's quite an interesting concept whereby if you can't stop abdominal bleeding, that you might take your patient to surgery. You would pack the abdomen with abdominal sponges. You would affect, if you saw a bleeding artery, obviously you clamp that off. If there was a fractured spleen, you might choose to take that spleen out at the time of surgery. If there was gross contamination with intestinal contents, you would temporarily close that leakage in the bowel, and then you close that animal's abdomen with the lap sponges and everything inside it. And once the patient has recovered or is more stable, say 24 hours later, you would then go and remove all the swabs and effect definitive surgical repair. So damage control surgery is not something that's practiced a lot in veterinary medicine. It is something that could be of use in patients with catastrophic abdominal hemorrhage or significant intestinal injury when a patient is very, very unstable. So check out that blog, and if you would like us to hold a webinar on that particular topic, we can do that. Now, there's this concept called hypotensive resuscitation that I alluded to before, where we might just want to restore our patient's systolic arterial blood pressure to 90 millimeters of mercury instead of 100 millimeters of mercury. This was outlined in a lovely article by Palmer, Lee, and Martin on in the Journal of Veterinary Emergency and Critical Care back in 2014. But it is a really interesting concept where we don't restore our patient's blood pressure to normal post-resuscitation endpoints because we're concerned about bleeding into the abdominal cavity or the lungs or the brain or something like that. And again, that's a subject of an entirely different presentation as well. Suffice to say, I've also written a blog on that, so please check that out. Lots of things we could have talked about tonight, but I chose acute traumatic coagulopathy instead. But hypotensive resuscitation, I've described already. It's where we give our patients shock rates of IV fluids, so 10 mils per kilo over 10 minutes of lactated Ringer solution. And we repeat those until we get our patient's blood pressure up to around systolic arterial pressure, up to around 90 millimeters of mercury. We're hoping for a mean arterial blood pressure that's up around sort of 65 or thereabouts. Okay, that would be nice because that would ensure that we had a reasonable kidney perfusion until we're able to then stabilize our patient with their abdominal wraps, for example, or maybe give our patients transfusion therapy and give them some more clotting factors, which I'll talk about in a second. So this is part of a strategy. It's not a means to an end in itself. This is not something that we advocate for many patients, but in some patients, we do decide to stop our shock rates of IV fluids a little bit earlier than we otherwise would because we're concerned about massive hemorrhage into the abdomen. And so if your patient has a coagulopathy, this is something you might want to do until the point where you're able to give your patient fresh frozen plasma or maybe whole blood transfusion. So hypotensive resuscitation, what does it actually do and why do we think about it? Well, it reduces the dilution of clotting factors and also minimizes the risks of dislodging blood clots as blood pressure rises during our intravenous fluid resuscitation. This is not a long-term therapy. Our patients still need to be resuscitated, but this is something we're going to do for our patients with a acute traumatic coagulopathy while we're doing the other things that we're doing, such as an abdominal wrap, for example, bandaging limbs, perhaps administering blood transfusions and so on. So we resuscitate to achieve a systolic arterial blood pressure of 90 millimeters of mercury or a mean arterial blood pressure of greater than 60, so somewhere between 60 and 70 millimeters of mercury. It sounds really good, doesn't it? It sounds like, well, I'm going to be super cool. I'm going to resuscitate my patient with just the right amount of fluids. Unfortunately, at this point in time, we don't have lots of high quality evidence. There aren't any real consistent recommendations at this point in veterinary medicine, and we do need to be mindful of the fact that if your patient has head trauma, if we only resuscitate a patient with traumatic brain injury to a systolic arterial blood pressure of 90 millimeters of mercury, their neurological outcome could potentially be 2 times worse than if we resuscitated them to a systolic arterial blood pressure of 100 millimeters of mercury. Because in head trauma, cerebral perfusion pressure is entirely reliant on systolic arterial blood pressure, and the minimum required for normal cerebral perfusion in a patient that has had traumatic brain injury is 100 millimeters of mercury. In human studies, they've found neurological outcome is 2 times worse if patients were resuscitated to a systolic arterial blood pressure of 90 millimeters of mercury over if they were resuscitated between 100 to 120. And that's the reason why a while ago I said my goal in most patients is to resuscitate to a systolic arterial blood pressure of between 100 and 120 millimeters of mercury. We also need to have that perfusion pressure in order to provide our kidneys with good blood flow, okay? Our kidneys and brain, very, very important. If our patient has continued signs of hypovolemic shock, it is likely that they might need more fluid therapy. If they are losing fluid, we might need to give them blood. We might need to give them more crystalloids as well. We might need to give them vasopressors. We might need to give them positive inotropes as well as part of their treatment. So hypotensive resuscitation, know that it exists. It's not a means to an end in itself. It's part of a strategy whereby we can just hold off on complete resuscitation in some patients until we can fix up our coagulopathy. Hopefully that makes sense. Damage control resuscitation. What is this? Well, it's similar to this hypotensive resuscitation, but essentially what we do is we add on early transfusion therapy to optimize red blood cell count. So if your patient is bleeding and it's got a packed cell volume of less than 20 to 24%, that's when I'm transfusing my post-trauma bleeding abdomen patient. I want to transfuse that patient to a packed cell volume of around about 27 to 30% so that my tissue oxygen delivery is maintained. I'm going to run the clotting time. If my clotting times are prolonged in any way, then I'm going to give them an early transfusion therapy. I'm not going to wait until the patient develops clinical bleeding. Now, this is different to the way we view transfusion therapy in patients with chronic disease or sepsis caused by pancreatitis, for example, or peritonitis. This is acute trauma, and acute traumatic coagulopathy patients do better with early transfusion therapy. In human data, human studies, they've found improved survival, less requirement for blood component use, that is red cells and protein, clotting factors and so on, and reduced organ failure in patients that have early transfusion over patients with delayed transfusion. Okay, so we can use our hypotensive resuscitation up to a point and then go, you know what, my patient has a prolonged clotting time or its red blood cell count is low, I need to transfuse my patient. So make that decision earlier. In patients with chronic disease or sepsis, like as I mentioned, perhaps peritonitis or pancreatitis and so on, we don't have strong data to support masses of transfusions in these patients to replace, say, albumin, for example, or even clotting factors in those patients that develop DIC, unless they have clinical bleeding. In these patients, this is an acute coagulopathy, and we usually have acute bleeding with these patients. We have a potentially life-threatening hemorrhage, so early transfusion therapy is warranted in these patients. We can also use antithrombolytic drugs. You remember when we talked about the pathophysiology of this disease, how we said that there's a massive activation of the thrombolytic system. And so we get not only procoagulant activation with platelet activation and stimulation of clotting cascade, we also get activation of protein C. We also get activation of the thrombolytic pathway as well. We can use drugs like tranexamic acid, for example, which is an antithrombolytic drug, to prolong the duration of blood clots. So in that dog that I showed you with the abdominal wrap on its abdomen, when we first saw this dog, it had some evidence of pulmonary contusions, and we used tranexamic acid very early on in that patient, okay, to minimize the amount of hemorrhage into that dog's lungs. We then gave him a second dose as well, which is generally what we do anyway, but by the time we were giving him his second dose, he'd already started to bleed into his abdomen. So to answer your question, Siobhan, yes, we do use tranexamic acid in these cases in dogs. We don't have any data in cats yet, but in dogs we do. The dose I've put on the screen there, 10 milligrams per kilo IV over 20 minutes, then 10 milligrams per kilo in a CRI over the following 4 hours. So basically 20 milligrams per kilo over 4 hours, but we give the first 10 milligrams per kilo quite rapidly. And you can repeat this after 6 to 8 hours as well. Good question from Jose. Great to see you again, Jose. Which blood component do we prefer in these situations? Do we use like plasma, or do we use whole blood transfusions? Some of this decision depends on what my patient needs. If they have a normal, if they have a packed cell volume generally that's above 25 to 27%, I usually just use fresh frozen plasma to get all the clotting factors that I need in that patient. But if the patient's packed cell volume is lower than 20 to 24%, that's generally when we expect to find patients becoming tachycardic. They may develop arrhythmias due to the physiological stress that decreased oxygen delivery to tissues causes. And so in those patients, I'll use probably whole blood in most of those patients, especially if there's any evidence of prolonged clotting time. You could use aminocaproic acid as well. I think less has been written about aminocaproic acid in dogs than tranexamic acid. So tranexamic acid is the one that we have the most data for, but they both do similar things, aminocaproic acid and tranexamic acid, as being antithrombolytic drugs. Damage control surgery. I've kind of got ahead of myself before. This is where we have surgery in which we try to obtain rapid control of intra-abdominal hemorrhage and gross contamination. If there's bleeding vessels, we tie them off, then we pack the abdomen with laparotomy sponges, basically to provide some pressure on those contused organs, and we close the abdomen up. And then we reopen the abdomen once our patient is stable, and we remove all of those lap sponges, and we effect definitive repair as we need. So that's what I've just written on this slide here as well. So that is what I had for you today. I just want to summarize over a couple of slides because I know we've branched off on a couple of little tangents along the way. So let's bring it all together. Acute traumatic coagulopathy is potentially life-threatening. It doesn't occur in all trauma patients. You, in fact, may not appreciate that it's going on in your patient unless you test for it. And that's the same for me as well. Many times in acute trauma patients, we might do a lot of things for our patient, but running a clotting time is oftentimes not at the top of our list in terms of what we're going to be sampling from our patient. But maybe it should be, because we might pick up a prolonged activated clotting time, or APTT, or PT, or thromboelastography, or roten readings from our patients. Okay, so include a coagulation assessment on a regular basis, so maybe every hour or so, until your trauma patients, especially those severe trauma patients, present to your practice until they're stable, because this is a potentially life-threatening condition for our patient. It has the highest risk in those severe trauma patients: big dog versus little dogs, dog versus a cat, dog attacks, any animal that's hit by a car, fallen off a high-rise building, those kinds of things, all the things that our patients can get up to and arrive in a state of trauma. Pig hunting injuries, gunshot injuries, and so on can all cause this sort of coagulopathy. The diagnosis: increased coagulation times in the face of significant trauma. You only need about a 30% increase or so in the coagulation times over the normal lab values to be suspicious that your patient might be developing a acute traumatic coagulopathy. The treatment for it is to arrest any hemorrhage that you can physically get to. So, bandage things that you can't physically get to, like the abdominal cavity and fracture sites. Judicious use of fluid therapy. So by all means, treat your patients for shock. Remember those blood pressure readings. Aim for 100 to 120 millimeters of mercury. If you've got lots of bleeding in your abdomen or your chest and you're worried about the patient bleeding, you might decide to resuscitate your patient to systolic arterial blood pressure of 90 millimeters of mercury, until you can get your abdominal wrap in place, until you can give your tranexamic acid, and then you may decide that you're going to give an additional bolus of intravenous fluid therapy. Warm up your intravenous fluid therapy. If your patient develops a low PCV, or if they show signs of developing a coagulopathy, then transfuse your patients early. And then damage control surgery might be a part of your resuscitation strategy if your patient is deteriorating despite your very, very best efforts. Interesting question here from the Reddit. If no clotting times are available, have we ever done clotting times just breaking a capillary tube? There is a test. Now, it'd be worthwhile looking at this one, because there is a test called the whole blood clotting time, and they use this in human medicine quite a bit. It takes 20 minutes. You need a glass tube to assess it. And essentially, they just put 2 or 3 mils of whole blood not from a tube, just directly out of the syringe into a glass tube. It can't be plastic, it's got to be glass. And you assess the clot at 20 minutes. And if there is no clot at 20 minutes or only a weak clot, then you have a diagnosis potentially of prolonged coagulation. It is not as sensitive as the clotting times you're going to run in your machines, but that is something that you could potentially use. Candace, fibrocartilaginous aortic thromboembolism. Then I'll just go back to your question. Does that develop sometime post-fracture? Does that tie in with that initial coagulopathy, that fibrocartilaginous emboli, or is that a separate phenomenon? It's a separate phenomenon from that coagulopathy. So that's just due to particulate matter that gets embolized into the systemic circulation as a result of the fracture. Thanks for clearing that up. That's awesome. Does increased abdominal pressure have any negative effect on ventilation in patients that might also have concurrent intrathoracic or rib trauma? Absolutely, it can, Christina. That's an awesome question. And I think that when you're putting these bandages on, that is one of the key considerations, that if you have a patient who's in respiratory distress, because they might have pulmonary contusions and they might have fractures, there is a limit to how much they'll tolerate in terms of being able to tighten that bandage up. So that is something that you really need to keep a close watch on, because if your patient is suffering from respiratory distress, you're going to need to ease off on how tight you put that bandage on. So in my experience, having said that, if you tighten your bandage to the point where you're still able to slide 2 fingers, not 3, but 2 fingers under that bandage, between the bandage and the skin, most of the patients that I have put those bandages on have still been able to breathe quite well. Generally speaking, I'm putting the bandage just around the outside of the ribs, sort of 10, 11, 12, and 13 there, or 10, 11, 12, around that sort of area. I'm not but if the patient shows any signs of breathing difficulty, then I'll generally just pull the bandage back a tiny bit. But in most of the cases, I haven't found that those bandages have caused significant issues if I haven't put them on too tight. Good question from Audrey. Andrew, sorry. I would like to ask how acute traumatic coagulopathy is linked with DIC. That's awesome. So DIC, okay, can coexist with acute traumatic coagulopathy, but they're actually different things. DIC, disseminated intravascular coagulopathy, is as it sounds. You could, in fact, argue that acute traumatic coagulopathy is kind of a subset of DIC, because we have widespread activation of clotting factors in circulation. We have heightened fibrinolysis as well. DIC, typically, we see this not so much in the acute stage of post-trauma, but we typically see it maybe 12 hours, 8 to 12 hours or later after significant tissue injury, because of the massive activation of clotting factors that occurs secondary to the inflammatory response that we spoke about earlier in this lecture, the inflammatory response that occurs following tissue trauma. So picture this: we have a tissue, it's traumatized, say at midday. And as that tissue is traumatized, we get activation of our clotting system. Maybe we get activation of fibrinolytic system. If this animal has significant trauma, we'll get acute traumatic coagulopathy. And that's going to appear quite quickly after our patient's trauma. Classically, we refer to DIC as something that is a consumptive coagulopathy, where we have consumed all of our clotting factors to the point we have none left, and then we start to bleed. So it's a consumptive type of coagulopathy, rather than necessarily having both massive activation of coagulation and anticoagulation system at the same time. So what I would typically expect to see after that significant trauma at midday is that I'm going to get recruitment of white blood cells into the interstitial spaces at 6 o'clock, occurring gradually from any time from right away up, and it's going to reach a peak about 6 to 8 hours after that trauma. So about 8 o'clock at night, that's when my inflammatory cascade is really starting to take off, and it will it will reach a peak at sort of 12 to 24 hours after trauma. And so that is the point where I end up with massive releases of huge amounts of cytokines into systemic circulation. And among those cytokines are a number of cytokines that cause clotting system activation, like huge quantities of platelet activating factor, for example. And that will cause massive consumption of platelets, so that when I measure my patient's blood, I take a blood sample at midnight, my platelet count, instead of being 200 times 10 to the power of 9 per liter, it might be 60 or 70 times 10 to the power of 9 per liter. And when I measure my clotting times, they might start to become prolonged then. And that is the classic disseminated intravascular coagulopathy. But you can get after trauma, but you can get that after, pancreatitis and all those other diseases like GDV as well. So hopefully that has helped a little bit answer that question. I really like that question. Can you use a drop of blood on a slide and a drop of saline to check for coagulation? Not really. They're not really reliable for checking the actual clotting. You could certainly, I have put drops of blood on a slide and noticed that 10-15 minutes later that it's still really liquid. But to be honest, I have not. I'm not aware that we can reliably detect coagulation just from a drop of blood. You're probably best to use a tube, but I would certainly go on to Google Scholar and have a look. In fact, I might do that for you. I might try to find an article on the whole blood clotting time, and I might see if I can include that in the notes for you as well. Lovely. Thank you so much for all of your questions. Oh, there's one more question. Never performed a tranexamic acid CRI prior. How do we practically carry this out? So the dose is just 10 milligrams per kilo over 4 hours. So that's just 2.5 milligrams per kilo per hour. So generally speaking, you just draw up the tranexamic acid. You can dilute it in saline and then just put that on a syringe driver and deliver that slowly to your patient over 4 hours or so. It's quite safe to use. If you've got a small enough syringe driver, you may not even need to dilute it in order to give it to your patient. But generally in the first 20 minutes, I'm usually giving that first dose of 10 milligrams per kilo of tranexamic acid just by hand. I'll inject a tiny bit every few minutes or so into the patient, and then we'll put them on a syringe driver, typically to put them on that tranexamic acid CRI for that following 4 hours or so. I hope that helps answer your question. Thank you so much, everybody, for coming along. It's such a lovely experience for me to see all of you here, and thank you so much for all of your fantastic participation. If you do have any questions that you come up with after the lecture finishes, just feel free to email them to us here at Vet Education. I'm more than happy to help answer some of those. And I hope that we see you all later on in the year. I hope you have a fantastic year ahead. We're still in the midst of all of this strange world that we live in with pandemics and everything else. So I hope that you and your families are able to stay safe and happy, look after yourselves, and we hope to see you many times during 2022. Thank you and good evening.